Melchert and I'm from the Department of Molecular Pharmacology of the University of Groningen. Today's date is March 30th, 2020, and this is a recorded class for the course Pathology and Immunology for first year pharmacy students. This class will be about restrictive lung diseases like pneumoconiosis and fibrosis. So in the classes about asthma and COPD, I already talked about the difference between obstructive and restrictive diseases. So now we're going to talk about these restrictive diseases in which the lung becomes really stiff and it will be difficult to breathe in, difficult to expand the lungs. So what is pneumoconiosis? Pneumoconiosis is a very expensive and complicated word for dust lungs. Pneumoconiosis is a lung disease caused by the inhalation of dust. And that usually affects men because they're in professions that require, generate lots of dust, like coal mining, building, etc. So the most common causes of pneumoconiosis are inhalation of asbestos, coal dust, and silica, and I'll discuss them one by one. So I guess one of the best known pneumoconiosis is asbestos. It's a natural fiber that has been used a lot in building materials because it's very fire resistant. Here you can see the use of asbestos, and here is the development of a special type of disease called mesothelioma that is the result of inhalation of asbestos. It's a cancer that is specifically in the membranes of the lung, in the pleura. And it took a while for us to discover this connection because there's a rather long lag time. As you can see here, it takes about 20-25 years for the disease to develop. As you can see here, the peak of the use of asbestos was around 1970. And then the first cases started to appear, and then the use of asbestos was prohibited. But since all these people worked a lot with asbestos in these times, we're still seeing the number of cases increase. So the peak of the number of mesothelioma cases was predicted to happen between 2010 and 2020, and that is exactly what has been happening. So how does this damage the lungs? Asbestos is a natural fiber that cannot be degraded by our body. Here you can see these fibers. They tend to be pretty big and too spiky and pointy to be phagocytosed by macrophages. So the macrophages will try to eat these fibers, but they cannot. They will die, and then new macrophages will come to eat the dying macrophages. So in the end, they know that they cannot eat this danger, and they try to isolate the danger, just like they do with tuberculosis. So they're going to produce pro-fibrotic factors to wall the fibers off. And this production of these pro-fibrotic factors leads to interstitial fibrosis, so fibrosis of the alveolar walls. And somehow, for reasons we're not too sure about, is that then also cancers can develop in the membrane surrounding the lungs, in the pleura. And that is called mesothelioma, and that's a very specific type of cancer for asbestos. It's hardly ever seen in people who have not been exposed to asbestos. Another pneumoconiosis is exposure to coal dust, and there are several ways that this can hurt the lung. The actual carbon particles are not very toxic, They can cause a focal dust emphysema, a special type of emphysema with mild dilation of bronchioles, but that's usually not very severe. But this exposure to coal dust is usually also combined with exposure to silica, because the coal is mixed with sand. So you also get exposure to silica, and when that happens, people tend to develop fibrosis. How that works, I'll explain in the next slides. And a lot of coal miners also tend to smoke, and that will aggravate the emphysema development. So Holland doesn't have any coal mines anymore, but the coal mines were in the south of Holland, and there's still a lot of men there that have developed emphysema from the exposure to the coal and the smoking. So what is so dangerous about silica? Silica, basically sand, and it's very fibrogenic, just like the asbestos. It cannot be degraded by the body, but usually they're small particles, and the macrophages will try to phagocytose these particles and digest them, but that doesn't work. Then they die, and then other macrophages will come in and try to eat those dying macrophages. So when that doesn't work, they start making these profibrotic factors again to isolate the silica and wall it off from the rest of the body, leading to fibrosis. So this is a section of a piece of lung of somebody who had been exposed to silica, and using a special kind of light, polarizing light, you can actually see the pieces of silica lighting up like little diamonds. It looks very pretty, and it's not a very nice thing to have in your lungs. And here you can see what the lung tries to do when it has been exposed to silica. This was an area where macrophages were exposed to silica and were trying to eat it, and fibrosis develops, so you get a fibrotic nodule. So here you see lots of immune cells, and here there are lots of fibroblasts that are producing scar tissue, and that's why you only see very few of these dark purple dots, which are nuclei. There are only a few fibroblasts in here that produce lots of scar tissue, and the scar tissue itself doesn't have nuclei, so that's why it's so pink. This fibrosis in the lungs is also part of another group of diseases called interstitial lung diseases, so diseases that affect the alveolar walls. And they could be either by inflammation or by fibrosis. So the acute, it can be an acute inflammation of the alveolar walls, or it can be a chronic inflammation leading to fibrosis. And here you see a close-up of a alveolar wall covered with type 1 epithelial cells, and here's a type 2 cell. It's a very thin wall, closely located to blood vessels, so there's easy exchange of gases. When there is damage, then there's blood leaking into the lungs, and that's not good. So then hyaline membranes will develop to plug that leak. And in some cases, this is not repaired in the correct way, and it will lead to the alveolar wall becoming thick and fibrotic, with lots of type 2 cells that are hyperplastic and proliferating to replace the damaged type 1 cells. And of course, this is a very thick wall, and it makes it very difficult to exchange gases. So do you remember what the acute type of interstitial lung disease was called? Well, in these times of corona, it mustn't be very difficult, because that is indeed respiratory distress syndrome, and not atelectasis or status asthmaticus. So interstitial lung disease, there are a lot of interstitial lung diseases. They're not very common, and they all have slightly different causes and slightly different clinical phenotypes. But in general, it's very difficult to distinguish them from each other. So if a person comes into the clinic with diffuse parenchymal damage, then doctors have a hard time trying to figure out what it is. So it takes a long time to diagnose. And then one of the most common interstitial lung disease is idiopathic pulmonary fibrosis. So fibrosis of the alveolar walls, and idiopathic means we don't know the cause. So in most cases it's unclear what causes the disease, but it leads to pulmonary fibrosis. So a little bit more about idiopathic pulmonary fibrosis. It's more frequent in males. We used to think that was because they were exposed more to dust, etc., because of their professions. But it does appear there might also be a biological cause for this. It usually affects people older than 60 years, and it's a grim disease, because by the time people get a diagnosis, their average survival is only 3 years. It's a very lethal disease, and we don't actually have treatments. There are now 2 drugs on the market that can well, not inhibit the decline of disease, but slow down the disease. So, but not by much. So people get a little bit more time, but not an awful lot of extension of lifetime. So what happens here? Here you see a normal alveolus, nice thin walls, easy to exchange gases, and when this alveolus becomes damaged and fibrotic, this wall becomes thicker. It's filled with scar tissue, which makes it hard to exchange oxygen. So people with IPF have a rapid decline in lung function. So usually within 3 to 4 years, lung function has declined so much that it's impossible to live further. But there are some phenotypes. So this is the rather slow decline of lung function. There are also people who have a very rapid decline. So these are usually the men, and women tend to have a slower decline. And in IPF you also have exacerbations. So something happens, a viral infection, and people get a lot worse all of a sudden, and this usually leads to a loss of lung function that is not regained again. So these people quickly lose a lot of their lung function and then decline again, and then lose lung function again with the next exacerbation. So do you know what a different name is for a fibrotic lung? Is this a cirrhotic lung, a honeycomb lung, or a sarcoid lung? In this picture you can see what it is. It's a honeycomb lung, and this name is based on the pattern doctors see on a CT scan. So this is a CT scan again. Here is the spine, the heart is sort of there as well, and these are the lungs. So normally this is sort of blackish with maybe a few of these white structures, but here you can see it looks like a honeycomb. There's lots of white bubbles inside, and that is the fibrotic tissue. And here you can see very nicely that fibrosis usually develops on the outside of the lungs and moves inward. So here this lung is completely fibrotic again already, and this here, it's still a little bit on the outside, and there's still some relatively normal lung tissue here. A clinical phenomenon of people with IPF is that they develop clubbing of the fingers. It's a very specific thickening of the ends of the fingers. In Dutch it's called trommelstok fingers, and this is also very specific for fibrosis. So you don't see this in people with asthma or people with COPD. It's very specific for fibrosis, and we don't know why that develops, but it's interesting. So what do we think causes IPF? So we don't know, because of course the name is idiopathic pulmonary fibrosis, but there are some theories, and the most well-known theory is that it's ongoing epithelial cell injury. So here you see an alveolus with a very thin alveolar wall covered by type 1 epithelial cells, the occasional type 2 cells, and then something damages those type 1 cells, and to repair the damage, in the acute phase you get hyaline membranes that will cover this hole here, but the local cells and cells of the immune system that move in will start producing repair factors to repair this damage. So you have some fibroblasts coming in that can make scar tissue, and they will try to replace the hyaline membranes here with scar tissue. Normally then this scar tissue would be degraded again, and you would get nice thin type 1 epithelial cells here, but because somehow there is repeated damage to the epithelium in IPF, this doesn't happen, and the fibroblasts keep coming in, keep making scar tissue until this whole alveolar wall is completely fibrotic and thickened by scar tissue. So in summary, what is thought to be the pathogenesis of IPF is continuous damaging of the alveolar epithelium, then fibroblasts moving in and proliferating to repair the damage. These fibroblasts transform to myofibroblasts that are very good at producing scar tissue. And the type 2 cells will start to proliferate to try and repair the damage to the type 1 cells. And one of the thoughts is that the type 2 cells are not up to their job. So either there's an innate problem in type 2 cells that they cannot repair the damage, or the damage is so overwhelming that they cannot keep up with trying to repair the damage.